Hey guys, Don here. Welcome to the $1,000,000 Minute, helping you get your practice to the $1,000,000 mark and beyond. I had a couple of questions that some docs brought up. I just wanted to address those because I think those are some pertinent things. Today is a Friday that I'm recording of, and one of the doctors said, according to Medicare guidelines, no one is supposed to do any care on patients except like podiatrists or DPM, NP, PA. Things like that. And in our practice, we are trying to use a nail technician. And he asked, am I just using just for cash pay nails and not Medicare? We're kind of experimenting with this format. I think I've been mentioning this for a while because we're wanting to be able to see more patients in a small amount of time. So we all do just a half day of nail care per week for the 4 providers. Before we used to kind of intersperse it, but we found that doing these kind of block half days works really well. And also for the nail tech, she is not as busy in the morning, so it works well for her to come in and help us. I kind of think of it as there's a lot of things that our staff do for us. For example, they put on Una boots, they would put on a cast, and all of these things we are monitoring. We are making sure it's okay, making sure it's comfortable, making sure it's on the right way. They're let's say dispensing DME. They're doing all these things, and we're not actually doing them. So we're delegating the actual procedural aspect of it, but we are checking it. And so for the nail care, we're at least at this point, and I might change my mind if anyone else calls to convince me, or we get bit in the butt about this. But I do all the documentation. I go see each of the patients. I do all the callus care still, and I, kind of like when we were in residency, where your attending goes in there and just fixes a few of the nails and things like that, and then they leave any of the difficult nails for me to do, like any of the ingrowns and things like that. So we're comfortable at this point doing that. I'll let you know if anything kind of changes. So this is a recording of a Friday, so I'm going to go over just the non kind of boring routine ones. So there were 33 patients, half day of routine, and then there were 30 open minute slots this day. So first patient was a routine, and they also had a nail avulsion on the lateral third digit. So this is one where he had a very deep ingrown nail on the lateral third digit. There was no redness, but when I took out the nail and cleared out all the callus in there, you could see that kind of erythematous area where the nail was digging in, or the callus was digging in. And so I numbed that up, and I called that a partial nail avulsion. That's kind of what it was called. It was not an IND, or incision and drainage, because there was no signs of redness or infection. Next patient, he is actually a 73-year-old patient of mine, and he's an endocrinologist that I see. And we were talking a lot about these new weight loss drugs that a lot of his patients are on. So skipping or not doing metformin for patients and kind of going all the way directly to these weight loss injections. He thinks it's pretty revolutionary, and so do I. I've been finding a lot of great results with patients with weight loss. Next patient was a 77-year-old man. He came in, we did, for some reason he did nail care, but he also got x-rays because of some hallux limitus or hallux rigidus, and we did an ultrasound-guided cortisone injection for him. And then we also did a orthotic to help with the function. So what I'm trying to do is, instead of just doing the cortisone, and then I'm explaining to the patients, okay, you have the pathology, and then you have the mechanics. And we have to fix the mechanics so the pathology doesn't continue to come back. So in this case, kind of severe hallux limitus, so I did a kind of an extension under the first ray, the hallux as well, in his orthotic. Next patient was concerned about nail fungus, so beyond the nail care, I did the nail sample for her. There's a patient I did a diabetic foot exam on, so I tend to do these, as I mentioned, a month before, a month after their birthdays. He was a little bit older. I did not do an ABI or a circulation study. I tend to cut that off at about 90 or so, because I don't think we're going to do any intervention based on that. All the others were just kind of routine. There's another diabetic foot exam. And then there was also another patient that came in for nail care. And he was wondering why we didn't do the Q10s on the same day, and I had explained to him that we have to do those separate days because of billing and insurance and things like that. So he's going to come back next week to do the Q10s. And then the last patient of the morning, actually no, this is the first patient in the afternoon. She's an 82-year-old female. She has a fifth med fracture. She had a follow-up. We got an x-ray. She's doing much better and has no pain. Onward, matrixectomy follow-up. Patient, she's doing fine. I did a fifth digit flexor tenotomy. This is a patient that I had previously done 3 other toes, and then when I did, so on her right foot, the 2 that were, I think there was the 3rd and the 4th that were kind of tight. I did those, and now the 5th was really contracted in, and so I did the 5th one. And I also I got kind of some feedback from another doctor. I was mentioning the concern about doing a flexor tenotomy on a hallux for a hallux ulcer like an ulcer on the tip of it, and he had done it for a few times. I haven't done it yet, so I'm considering doing that either with an 18 gauge needle or a kind of a very small blade in there. If you guys have any tips, please shoot me an email. I'd love to hear what's working for you. Next patient was a patient with an ingrown toenail, so I did a nail avulsion bilaterally on both on the lateral side. Next patient, this is my MVP patient. She was here for EPAT number 2, and she also got an ultrasound-guided amnio injection. So she has kind of chronic plantar fasciitis that's been there for a long time, 55-year-old female. So I tend to find my kind of sweet spot is not really the athletes as much. It's more these like 55-year-old females that really want to get better faster. I did some searching within ChatGPT to kind of how can I explain the difference between Shockwave and then why the benefit to Amnio. And I think the benefit to the Amnio, and what I tell patients, and I'm already saying like Shockwave is 82% effective. It speeds up the healing by 50%. Like how can anything, and it has the most research. How can anything get better than that? I think the benefit of the Amnio is that it is synergistic, so it works together to even get better results. And I think there's a little bit more pain relief. I tend to find it when I do the Amnio, patients have more pain modulation quicker than the Shockwave. Many times the Shockwave takes many, many weeks before we start seeing the pain improvement. But I think that the Amnio helps people to feel better quicker. Could also be because I'm putting them in a walking boot afterwards. So she brought her own walking boot, but that was my MVP patient. She has another number of sessions. Next patient was a patient that had onycholysis. This was kind of a challenging one. She has onycholysis. She doesn't believe it's her shoe that's causing the nail to detach. I came back. I saw her back, and there was no fungus in the nail. But there was just that lifting. So those are kind of the challenging ones. If you guys have any great solutions for these, like distal, hallux, onycholysis, no fungus, sometimes I put Onifix on these, but most of the time I'm telling people about their shoes that are problematic. There probably are other things that it could be. If you know other things, let me know. Next patient was this is a patient. He is a 66-year-old man. He had a lot of calluses on his foot. We got an x-ray. His pain was on the left lateral fifth med head area, and he had a really big diffuse callus. When I trimmed that down, it came down to a real central core, which we call a porokeratoma, and so I did lesion destruction on that one, and then I trimmed the other calluses. And I told him just to come back periodically to do the calluses, and I think the callus just got too big, and so that I did an x-ray on him because of the foot pain, and then he'll just come back as needed when that hurts, or if it does hurt. Another patient, this actually might be another kind of MVP patient. This is a 60-year-old man kind of working on running a marathon, very active. He has some chronic Achilles tendon pain, and I did another ultrasound today, and he has some thickening, widening of the Achilles, and some effusion in there, and it's just painful. So we did initially first 3 sessions and a 6-week follow-up, and then now I'm going to do 4, 5, and 6. And I also recommended doing for him an orthotic to reduce the kind of the impact and help reduce the torsional aspect. I don't find that orthotics work a ton on Achilles per se. Yeah, maybe the heel lift portion, but I think sometimes by stabilizing the heel and reducing the torsion in the Achilles, it can help that. Next patient was a Swift number 2. This is a 69-year-old man. I don't see many warts on 69-year-old men, but he had one. Next patient, this was my last EPAT for this patient, Kelly. She's a 51-year-old female, and she had Achilles tendinitis at the level of the insertion, finishing Shockwave number 6. Now, it's hard to do 6 Shockwaves on someone that has insertional Achilles just because it hurts so darn much, and it takes so long to get better. And I just really prepped her when she finished, like, I'm going to see her in 6 weeks, and I don't expect 100%. Maybe 6 weeks after that, I would expect it to be much, much better, but it just takes time for that. Next patient was, this was a tough one. This is like a 340 patient, and she was a third opinion. So she had third opinion for really bad ankle sprains, really bad ankle arthritis. She had some spurring in the anterior aspect of the ankle. She had on her MRI bone marrow edema both in the area of the tibia and the area of the talus, and she was unsure what she should do. But at 46, she's really not a candidate for an ankle replacement because she's too young, and she's not really a candidate for an ankle fusion, or she doesn't want to be a candidate for an ankle fusion. They gave her a couple of options. She saw 2 different orthopedists, so once again, I'm opinion number 3. And I tend to focus more on the non-surgical, if you're all listening to this for a while. And so I talked to her about an Arizona brace, which someone else did as well. I think an Arizona brace would kind of mimic a fusion. That's how I kind of explain it to patients. But I also think she might benefit from some focused Shockwave to get down the bone marrow edema. A lot of times the pain from the arthritis isn't so much the arthritis, it's more the bone marrow edema. And if we can get that down with the focused Shockwave, that might benefit her. So I did talk about that with her. And then the last patient was a plantar fasciitis pain that's getting worse. We started the meloxicam, morning stretch, foam rolling, thing like that. And I'm going to see her back in 3 weeks to see how it's doing. So that was the day. Once again, thank you guys for listening. I've been getting a lot of emails. I'd love to hear from you. Donna at podiatrypracticemastery.com. If there are other things that are working for you that you think I should share with everyone else that I don't do, I'd love to hear it from you. If there's things that you're questioning, send those to me as well, because it'll help me get better. I'm humble and willing to learn, and I like to share this with other people. Hope you guys find this beneficial. If you want to do an audit on your kind of practice, how you practice, I do have an audit on my website, podiatrypracticemastery.com, and go to do your audit of your practice. Just ask a whole bunch of questions about how you're doing things, and I think even it's very kind of reflective. Even if you listen to that, I think it's going to really give you a benefit by listening as you do the questions to think of, by the way I ask the questions, things that you could add and improve your practice. Okay, have a great day.